Okay. Welcome. Welcome, everyone. Just going to give it a few more minutes. All right, welcome. Okay. I'm just going to get this started so we can stay on time. So everyone, hello. Welcome to today's webinar, Scalp Cooling 101. I'm Megan Claire Chase, and I'm the Breast Cancer Program Director and host of our BC Life podcast here at Share. Now, I'd love for y'all to put in the chat where you're joining us from today. That would be awesome. And before the presentation begins, I'd like to tell you a little bit about Share. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. Now, we have a few housekeeping reminders for you. All participants will be muted during the presentation. And as you've seen, the chat is enabled. So feel free to write comments, engage with each other in the chat. Just make sure that you select everyone when using the chat. And once our fabulous speaker today is finished presenting, we'll begin the Q&A discussion. Please submit any questions through the Q&A section at the bottom of your screen. Remember that the speaker is unable to give specific medical advice, so please keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button on the bottom of the screen and selecting the subtitle option. This webinar is being recorded. We'll share this recording in a few weeks with all of the registrants, and it'll be added to our website. So now, everyone, I would like to hand it over to Dr. Nangia to introduce herself. Dr. Nangia, the screen is yours.
Yeah, so my name is Julie Nangia. I'm an associate professor at Baylor College of Medicine, which is part of the Dan L. Duncan Comprehensive Cancer Center in Houston, Texas. So I am a practicing breast oncologist, so I see a lot of patients that have breast cancer, both at our academic site, and we have a site for uninsured or underinsured patients that I go to as well. And as part of academic medicine, I do a lot of research, and I'm honored to have been the national principal investigator for a trial called the SCALP trial that led to the FDA approval of the Paxman scalp cooling device. So I'm going to share my screen. Okay, thanks. I think it'll let me now. Yep. And today I'm going to talk to you a little bit about scalp cooling, what it is, how it works, and how you can get access to it. And just like they said, if you have questions along the way, just put it into the chat box. So my only disclosure is that Baylor did get clinical trial funding from Paxman to do the clinical trial that we ran. So to give you a little bit of background, patients that have breast cancer or any cancer, sometimes chemotherapy. And the reason people have chemotherapy is that there can be tiny cells in the body, what we call micrometastatic disease, and that can cause cancer to recur, to metastasize. So chemotherapy, the hope is that it would kill these tiny cells and cure more people of their cancer. Unfortunately, as you guys all know, chemotherapy can be associated with a lot of side effects, including hair loss, what we call chemotherapy-induced alopecia. And women really rate this as one of the most severe and distressing side effects of chemotherapy. And, since the 90s, a lot of countries have been able to have access to scalp cooling devices to prevent this hair loss. And in the clinical trials done in these countries, the success rate was variable. It was kind of between 25 to 50%. So let me kind of explain how scalp cooling works. So this is, can you guys see my arrow? I hope you can. There are different phases that the hair follicle goes through. And the way chemotherapy works is that it attacks cells that are rapidly growing. So you have the growth phase in the anagen area. And so chemotherapy often causes hair loss because of that. So when we use scalp cooling, what we can do is we can actually cool down the hair follicles, and that does two things. One is that it constricts the blood vessels so that chemotherapy is not delivered in as high amounts to the hair follicle. And the second thing is it slows down the enzymes that are in the hair follicle. And if you, on the bottom right, if you look at this hair follicle, if we look at it under a microscope, you can actually see changes in hair follicles in people that are on chemotherapy. So this is an example of what a scalp cooling device looks like. There's a couple of companies that have these devices in the US, and it's basically, to put simply, a mini refrigeration unit that has this cap and it circulates a coolant. It kind of has these tubes-like structure. And the patient will wear this inner cap and this outer cap, and they'll wear that before, during, and after chemotherapy. And the beauty of these devices is, as you can see, you can connect it to the machine, but patients can disconnect to use the bathroom or change locations. And before we had scalp cooling devices, you've probably heard of cold caps. And cold caps are basically like ice packs, and patients would bring these big coolers of these ice packs that they would put on their head, and they'd have to change out every 30 minutes. And they'd be very, cold going on, and they thaw out, and they have to be fitted every time. So it was very cumbersome to use. So these devices have a constant temperature. They're much more comfortable. And because they're not so labor intensive, this is something that a lot of infusion centers are starting to offer. So one question I get asked is, well, they've had this in the UK since the 90s. Why did it take so long to get into the United States? And one of the biggest reasons is that devices have very stringent approval processes through the FDA. And the cold caps have been in the US for a long time, but those aren't devices. So they didn't have to go through that same process. And I actually started the process of opening this clinical trial in we talked about it in 2010, but I probably really started the process in 2011 to give you an idea of timelines. And we went back and forth with the FDA for almost 3 years because they had some major safety concerns. They were worried about scalp metastasis and will using these devices cause for cancer to come back in the scalp. And there was 2 big clinical trials that were done that show that there was no increase in the amount of scalp metastasis in patients with solid tumors, and it didn't affect overall survival. And so the first device was cleared by the FDA for scalp cooling in the US in 2015 in December. And we'll go through some of that data, but that was a non-randomized data that looked at only a type of chemotherapy called taxanes, and about 2/3 of patients kept their hair in that study. So this first, if you look at the overall survival safety study, this was a study that was done in Quebec, and there were about 13,000 women. And in this study, they looked at people for over 6 years, and they didn't see any difference in survival or recurrence of cancer in the scalp in this study. And then this is another study that was done in Munich, and they looked at many patients. The database actually had over 33,000 patients, and not all of these patients had scalp cooling, but the ones that did. the scalp metastasis rate was like less than 1%. And with no scalp cooling, it was between, 0 to 3%. So very similar. It wasn't any different. So based on these studies, the FDA allowed these trials to happen. And then there was another meta-analysis that happened after this, and it looked at 24 different studies, and they really didn't find any incidence that was higher with scalp cooling. So it is safe. That's a question that I get asked a lot. So there were two big trials. The first was conducted by Dr. Hope Rugo, who's, you've probably heard of her if you're into educational talks, but she's very famous in the breast cancer world. And this study was at 5 US medical centers from August of 2013 to September of 2016. And they looked at patients that had early breast cancer and were getting chemotherapy with a class of drugs called taxanes. So these are drugs like docetaxel or paclitaxel that you may have recognized those names. And they consented 132 patients, and they did this, it wasn't randomized. They used these retrospectively matched controls. So everyone enrolled received the device, and they were assessed for alopecia or like hair loss, quality of life, and device safety. And in the clinical trial, 106 were randomized to the device, 101 were included in the analysis, and there was these 16 kind of retrospective controls. And so if you actually look at hair retention, so they use something called the Dean score to see if people kept their hair. So anything in a shade of purple is considered hair retention. So 0 is like mild hair loss. 1 is a little bit of hair thinning, and purple is like they still kept their hair but didn't need a wig and had more than half of it. And 3 and 4 is more significant hair loss, what's in the shades of orange. So about 2/3 of people kept their hair. And then in this, these are the different kind of regimens. You guys as patients don't have to recognize the names. But with drugs like taxanes, like paclitaxel, 100% of people kept their hair, which is pretty incredible. They did see some hair thinning, but with other taxanes, so this T is like docetaxel in most of these regimens, about 2/3 of people kept their hair. And they didn't have anyone that got what we call an anthracycline treatment in this particular clinical trial. And so if you look across like this chart, the first column where the thing is, you could see like they kept all of their hair. That's a Dean score of 1. And on the far right, that's a Dean score of 4. You can see that they have pretty significant hair loss and would need to wear a wig to be comfortable. So in this study, they also looked at safety, like are these devices safe to use? And the most common side effects were headache, itching, skin pain, and discomfort. And they specifically did not see any skin or scalp metastasis in this study. So most people tolerated it very well. Most patients had most of their chemotherapy. And when patients kind of described how they felt using the device, what they described were feelings of chilliness or cold, headache or scalp pain, and none of them were incredibly significant. So the conclusion from the study was that this DigniCap system did prevent hair loss in about 2/3 of patients receiving this non-anthracycline-based chemo. And based on these data, the FDA cleared the use of the system for scalp cooling in December of 2015. So this was the first device that was allowed to be used in the United States. So the scalp trial is the clinical trial that I conducted with colleagues across the US, and it was a similar study, but this was a randomized trial. It's the only randomized trial with scalp cooling that's been done in the world. It was open at 7 sites across the US, including 3 academic centers, which included Baylor College of Medicine, where I work at, Cleveland Clinic, and Memorial Sloan Kettering Cancer Hospital, as well as some US oncology sites. So in this study, patients were enrolled. They were randomized in a 2-to-1 fashion, which means that out of every 3 patients, 2 patients received this device and 1 did not. And then they were assessed for, keeping their hair, how they felt on it, and was the device safe. And we used a different scale called the CTCAE. This is what's more commonly used in clinical trials that are looking at side effects from chemotherapy. And 0 is no hair loss. 1 is like up to 50% not needing a wig. And 2 is more than 50% of normal needing a wig. So it's a very kind of simple way to look at things. And so this is an example of a typical experience patients had. This is grade 1 hair loss, and this is, you can see like some thinning, but not terrible, right? And this is the baseline for these same patients. So they know, their families probably know, but if they were going into public, a lot of people would not realize they'd had a lot of hair loss. And then this is grade 2, where it's pretty significant. You can probably tell that patient is getting treatment with chemotherapy. We also did a patient-reported comfort scale, and we'll go through those results, as well as a couple different questionnaires. So we designed the trial to look at 235 subjects, but we had this pre-planned interim analysis for efficacy, because remember when I originally talked about these trials in other countries, the efficacy varied so much, so we weren't sure how effective these devices would be, but it stopped early because the devices were incredibly effective. So in the analysis for our trial, we had 130 patients that got the device and 54 that were control. And we did, of note, have 6 patients that decided to go off study. 4 of them because they thought the device was too cold or uncomfortable, 1 because of anxiety, and 1 because they felt like the hat made them claustrophobic. And I mention this because most people think the device is very comfortable or, tolerable, but there's some people who really cannot tolerate the device. And then when we look at our results of our primary outcome, you can see that this is after 4 cycles of chemotherapy. So success is in this yellow and failures in purple. So people who did not have scalp cooling, all of them lost their hair where they felt like they needed a wig. And in people who had cooling, 53% of patients kept their hair, so about half. Okay, and then if you look at the different types of chemotherapy, so this taxane class, it was what was used in the prior study. About 2/3 of patients kept their hair with that type of chemotherapy, very similar result to the other trial that was done. But this class of drugs called anthracyclines, so this is what people call the red devil, the doxorubicin. Only about 1/4 of patients who received that treatment kept their hair. So the type of chemotherapy does make a difference in the amount of hair that patients can keep. And I'm going to go into types of chemotherapy a little bit later in this talk again. So if we look at adverse effects, the most common were headache and nausea, not very high amounts of people. And then there was very kind of uncommonly in the less than 1 to 3% range of dizziness, ear pain, scalp pain, itchiness, dry skin, those type of things. And we did have 1 patient where they had a little bit of breakdown in the skin because an area of their scalp got very cold. So these things can happen. They're very uncommon. The majority of patients rated the device as reasonably comfortable. Only about less than 10% of patients said that it was uncomfortable, and just a few patients thought it was very, very uncomfortable. I will say this is, you have to remember that 6 patients stopped the trial because it was uncomfortable and they weren't counted in this analysis. So there are some people who cannot tolerate the device. And then we did several of these quality of life assessments, and they really didn't show any difference. But I will note, at the time the study was conducted, we didn't have any like chemotherapy hair loss specific questionnaires. And there's a lot of data that has come out showing, yes, it does matter to patients in terms of like self-esteem and psyche and sexuality. So when we give breast cancer treatments, there's different regimens. So everyone gets at least 4 cycles of therapy, but some people have 6 or 8. So if we looked at completion of chemotherapy, about 46% of people kept their hair. In patients that got only taxanes, about 65% of people kept their hair. And in patients that got both the taxane and an anthracycline, about 15% of people kept their hair. And then we also need to realize that when we did this study, it was the original prototype of the device, and there were some problems with the way it fit. And since then, there's more like cords and clips, because when you fit that device, the key is really not to have any gaps, or that area of the scalp will not get cold enough and you'll lose hair in that area. So we did have that problem in the beginning of our trial. One thing I do want to point out, so we did have one site which used this, what we call dose dense chemotherapy regimen, and they did get adriamycin and cyclophosphamide first, followed by often paclitaxel and carbo. And 2/3 of people kept their hair with this. So just because you're getting adriamycin does not mean you're going to lose your hair. And this is why I point out that that fit is very important. And you can see here like rates of 18 and 40%. So we do see that. And in patients who only got paclitaxel, the hair retention rate was 100%. So in my mind, if there's someone that can have 2 chemotherapy regimens that are equivalent and hair retention is important to them, maybe this would decide what kind of treatment I gave them. And then this is another one where it was like, 75%. So we see high rates. Now, if anyone on this call is like thinking about getting scalp cooling or knows someone who's going to get scalp cooling, a lot of the doctors aren't as familiar with the data as I am. So I think it's good to be your own advocate sometimes. But the Penguin is a brand of cap. It's not a device, but they're, like I told you, very effective. And what they showed was that in people that got that adriamycin chemo first versus second, there was almost a doubling in the hair retention rates. And this has been observed with a lot of trials and a lot of different people. And I think we see this for 2 reasons. One is because no matter what, you're going to have some hair thinning. So when you give that adriamycin second, there's less hair, and that scalp and the hair follicle is cooled to a lower temperature. And they have shown in the lab that lower temperatures do cause more hair retention. The other reason I think this is important is weekly paclitaxel is given for 12 weeks in a row. So they're wearing this device for 12 weeks in a row with a regimen that causes less hair loss. So they get really good at fitting it. So I think it's really a combination of that fit and that slightly cooler temperature that's leading to this. So the conclusion from the scalp trial, which I helped conduct, was that the scalp cooling devices are highly effective. The Paxman scalp cooling device received FDA clearance based on these results. We really focus this on breast cancer, but we really want to be able to use scalp cooling for all types of tumors, not just breast cancer, and mainly solid tumors. These are not safe in like leukemias or lymphomas or what we call hematologic malignancies. And we need more studies looking at the impact on psyche and body image as well as quality of life. So the other thing that happened after these initial studies is a lot of the data with scalp cooling was actually done in the Netherlands. So they have this very large Dutch scalp cooling registry. And they looked at, you don't have to know what all this means, but they looked at all these different chemotherapy regimens. And these are used with various solid tumors, lung cancer, GI cancers, testicular cancers, things like that. And this data from this Dutch scalp cooling registry actually led to the FDA expanded approval to allow scalp cooling to be used for all solid tumors. So anyone that has like a solid tumor cancer. Beyond breast cancer, it does seem to work, in the stage 4 setting. We use drugs like eribulin or Doxil. It's more effective with certain drugs like epirubicin. When we give those taxanes and anthracyclines together, they don't work. And there are some contraindications like that hematologic malignancy I mentioned, a drug called oxaliplatin, and a few other things. There is also this great international group that I'm honored to be part of. It's called CHILL, and it's this cancer-related hair loss group. And they're really trying to prevent loss of hair from any type of cytotoxic therapy. So anything that we do like radiation, chemo, those type of things. And so this is a great website, but they have this decision aid tool, which is helpful. And I find this more helpful for like metastatic patients that get regimens that we don't give as often. So you can actually go to the site and put in the chemotherapy. I just put in navalbine as an example here. And it'll say that the chance of hair loss with scalp cooling is only 13%. So meaning that 87% of people who got this chemotherapy regimen will keep their hair. So that's pretty good. So this decision aid tool can help patients decide if this is something they want to do and if they have a good chance of keeping their hair if they use it. The other interesting thing is, some patients will lose their hair where they need a wig, but they'll ask me, should I keep wearing this device even though I need a wig? And I'll tell them, it might be worth considering for two reasons. The first is shown here. And what you can see is in this top graph, patients, and the green means that they have no hair loss, and the yellow is like grade 1. You can see that that green bar goes up much sooner than in the group who stopped using scalp cooling. So that by 7 months, 41% versus 13% of people felt like they had no hair loss. And at 13 months, it was like 66 versus 30. So it did make a difference in hair regrowth in this study. The other thing that is not commonly talked about by physicians is that this drug docetaxel does have a small risk for permanent alopecia. It is very uncommon, but it does happen. And there was a study done in Spain that really showed that if you use the scalp cooling devices, that they did not see any permanent alopecia. So that is the other reason to think about using these things. So when I talk to both providers and patients, I think if you're thinking about using scalp cooling, we really need to make clear expectations. We need to tell patients that you are likely to lose some hair and have some thinning, and that most people will lose about 30% of their hair. We need to really define what a success is up front. And I usually define that as not needing a wig or a scarf. But even if they do need a wig or scarf, maybe we continue it knowing that the hair will grow in fuller and faster, right? I put the ownership on the patient. So most of these devices have websites and guidance where the patients can learn how to put on their own device, how to get it to fit better. And that fit is really key to having a successful therapy. For providers, I really encourage them to know to sequence the chemotherapy with the agent that causes less hair loss first if it's equally effective. So in breast cancer, I would recommend, for example, weekly paclitaxel followed by the adriamycin. And for patients, we also want to avoid stressing the hair follicles. So no hair dye during treatment, straighteners, curlers, to use sulfate-free shampoos and conditioners and to comb their hair. And the company that I've worked with, there's several companies that have this as Paxman, so you can find more information at their website. So I'm going to kind of open it up for questions in a minute. But if you looked at this picture, so one of my patients is in this picture, and she had adriamycin and Cytoxan followed by a taxane therapy in that order, and she kept her hair. She had what we call grade 1 hair loss. So I'm going to let you guys guess in your mind who she is. But this is my patient, Sarah. She gave me permission to share these with you. And what she wanted me to tell you is that scalp cooling really allowed her to fight cancer on her own terms. You can see in this picture on the right, she has these sweet nieces, and they never knew she had cancer. When she was diagnosed with cancer, she was in college, and she was very private. She didn't really tell her friends what was going on. And she was able to kind of continue to live as normal a college life as you can live while you're getting chemotherapy. So I do think that it does allow people anonymity, and that, they can have a little bit more privacy when they're going through something as difficult as a breast cancer diagnosis and chemotherapy. And then I'm going to turn it over.
Thank you so much for that very informative presentation. I definitely have a lot of questions. And some of these, again, were submitted with registration. So you know, when you talk about the scalp trial, were men part of that? Because we don't want to leave men out of the conversation, though it's rare, they do get breast cancer as well.
Yeah, so the devices are approved for men. It's very interesting, the FDA process. So when we were designing the trial, the FDA had us leave out a lot of patients, and you couldn't have any baseline alopecia. And so breast cancer is, men were allowed on the trial. We didn't have any men in the trial because most men are older when they're diagnosed with breast cancer, like in their 60s, 70s, 80s. And most of them have a small amount of alopecia by that point, which would make them ineligible. But it certainly does work in men. I do think it's an important issue for men. But there was some very specific criteria that just didn't allow any men to enroll on that particular trial.
That's interesting. So you talk about like the fit of the cap. Like, do these come in different sizes? How do you know what size cap for your head?
Yeah, no, that's an excellent question. So for the devices, and I'm most familiar with Paxman, but I really think they all work the same. The way you do it is we actually have a visit where the nurse gets fitted, and I usually at my center pair it with a chemotherapy teaching visit. And our nurses have been trained in how to fit the devices. So we have a trial set that we use, and it comes in a small, medium, and large, and they're different outer sizes. And we just make sure that it fits right and the right portions of the hairline are covered. Um, what's very interesting that people don't realize, because it's kind of complicated, is not everyone has the same skull shape. So for example, when they try to do this trial in Japan, everyone lost their hair because the devices just didn't fit right. So they had to come up with the specific design of the cap for that country. So, one day in the far future, maybe we actually imprint the skull and get this device to fit perfectly, right? That would be amazing. But right now, we kind of have these sizes that fit most, but not all people, right? And so that's why, like, adding in these cords and clips to help make sure that there's no gaps and for patients to be comfortable putting it on themselves, right? Because, the way it works in the US is you buy the cap and then you pay for the specific treatments through the company. Recently, I'm sure this question is going to be asked, so I'm just going to go ahead and answer it. Recently, insurance has started paying for these. There actually is both so the American Medical Association, what we call the AMA, issues CPT codes, which is how we could kind of like bill and pay for things. But then like the centers that offer scalp cooling have to set up this program where they can actually buy the caps and like submit it to your insurance and have it paid. So these are recent codes that have come out. In the US, scalp cooling at most locations is self-pay, but some sites have launched this program. I'm at Baylor College of Medicine in Houston, and we're in the process of trying to launch a program where we try to get insurance approval before patients started, but it's a complicated process to do that. Right. And I do think that once we're able to tell a patient almost immediately, yes, your insurance will cover it, that more people are going to want to do this because, hair is important, but finances are important too. So I definitely see some people struggle with that decision.
I mean, absolutely. And like, if it's without insurance, is there like a range of how much the device would cost if it's out of pocket?
Yeah, so I'm only familiar with the Paxman cost, and their maximum out of pocket's $2,500 at this time. That could change in the future, but that's maximum, like a lifetime. So like if you're a metastatic patient, that would be the max. And I think it's around $500 to buy the cap, and then there's a per use cost. Ooh. And so that's, I think, why it's important to get insurance to cover it. There are also foundations out there like Here to Stay that if you cannot afford it and you're under a certain income level, you can get subsidies and grants to pay for this because, the company and these nonprofits want people to have access. I know there's some institutions that have philanthropic donations that cover the cost of scalp cooling for everyone. So there's a lot of neat programs out there. Once we have the insurance pilot program kind of up and running, if for some reason the insurance won't pay for it, if the patient's under a certain, salary level, the company will actually offer free scalp cooling to that patient. And I'm sure, other companies have programs. I'm just not as familiar with them. So I do think everyone is aware that it can be expensive. I have had a lot of patients that have retroactively had their insurance reimburse them for the cost. But, that if you've ever had to try to fight with your insurance company, it's not the easiest task because of all the paperwork and the back and forth.
Mm. So, another question is, does this work in textured hair, like for, African Americans, Latinas, Asians? Like, does it work? Because I couldn't really tell in the slides. And then does it work if a patient has had like relaxers in the past?
Yeah, so I don't think past treatments impact things as much unless if the current hair follicles are damaged, because those are on the inside, right?
Mm-hmm.
And so I think it's a more complicated question than people realize. So there are different hair types. So African American hair is very different than other ethnicities. And we actually had very bad success with this in the beginning. And we learned a lot of things. Like a lot of African American women had braids in. You have to take that out or it won't cool the scalp to the right temperature.
Mm-hmm.
And the hair type is just different. And so we were telling people to dampen their hair and put conditioner so that fit is better. And you actually need to use like grease or oil-based therapies for African American hair, or it like actually expands the hair instead of, flattens it. So there's actually a lot of research going on now in the different like ethnicities and how to increase the amount of hair retention. I think in the Asian population, it was more related to scalp shape, like that example I gave to you with Japanese women versus hair type.
Mm-hmm.
But these are just there are definitely some ethnic variations out there that we are kind of aware of. And there's a lot of research going into this. And, at our site, we actually, we had 2 locations. So one is like our academic clinic, which is kind of like a private practice clinic, but a fusion because it's an academic center. But we also, in Houston, we have this hospital system called the Harris Health System, and it serves like the uninsured or underinsured patients in Houston that are residents. And so we had this trial opened there too, and we had a lot of Latinas on it, and they had a lot of success with hair retention. So I can speak to that population. So I really think it's that African American subtype of hair that we have some work to do.
And even thinking those, who are biracial as well, like, different textures. I did lose my hair, and I had the ACT, but my hair came back curly. So y'all, I never had curly hair. It permanently changed my hair pattern. So another question is like, you talked about some of the side effects from it. Like, what are different ways that patients can minimize discomfort? Because it said like cold and all that. With that coldness, can you also at the same time have your hands and feet in the ice water, in the ice, to help prevent, chemo-induced peripheral neuropathy all at the same time?
Yeah, so I'm going to answer those as 2 questions. So the first question is about comfort. So you can wear a headband, which will help with any discomfort where you don't have hair, right? Because you don't really need that part to get cold. And you can cover your ears with the same thing. You can wear scarves. Most infusion centers have blanket warmers that can help. But I've worn the device myself because I wanted to know what it felt like. And you know that sensation when you jump in a pool that's cold, like it's a little uncomfortable for the first 10 minutes or so, but then you just kind of get used to it.
Mhm.
So I think that's what the vast majority of patients experience is that, it's fairly comfortable. The first 10 minutes or so are like, wow, this is cold, but then it's not so bad, right? And patients do really well on it. Now, the second question is about neuropathy. And, I don't know how, we didn't really talk about this. So let me give a little bit of background for those of you who may not know. But certain types of chemotherapy, like taxanes, paclitaxel, docetaxel, can cause what we call neuropathy or permanent nerve damage in the fingers and toes. And a lot of people have numbness, some people have pain, and that can be permanent after chemotherapy. So this is a big thing that we look for. It's very hard to predict who will develop neuropathy and who won't. And there are a lot of clinical trials, anecdotal things out there, but a lot of patients will try to wear like cold gloves, like kind of like the scalp caps, right? These haven't been well studied. There's not devices. You just buy them and you use them. And what the studies, just to kind of summarize, have shown that probably a combination of cold therapy and compression worked the best. But your fingers are not able to tolerate the same temperature as your scalp, right? Your fingers are just more sensitive to cold. So I know, like I said, I work with the Paxman group the most, but they've actually developed a really cool device, and it's in clinical trials now. We're about to open it at our center to look at preventing neuropathy. But patients are wear cold gloves and cold feet, and there's like a control kind of sham arm, but they either get like a control, compression, and cold. So I think the data's been a little bit mixed out there about what works to prevent neuropathy. And so those trials are ongoing with devices, which I think will be more regulated because of the FDA regulations, and we'll actually get some really good clinical data. So this is open through the SWOG, which is a national cooperative group at many sites across the US. I do have patients, like, for example, I recently treated a surgeon. And so having sensation in her hands is her livelihood, but
Right.
also being cured of your breast cancer is very important. So she had to have this taxane type of chemotherapy to have the best cure rates. So she did buy like the cold gloves and, feet, and she brought it in a huge box, in dry ice, and wore them. It's kind of uncomfortable. She stopped using them after a while. So I think people have variable reports with that, but that is available. I think it's hard to quote to patients what the success rate would be with that, but it definitely does help prevent some neuropathy for some patients, right?
Mhm.
And there's research being done with other medications and drugs for that specific topic.
So and maybe I might have missed it on the slides, but with the temperature, like how cold does it is it supposed to get to have maximum, you know, efficacy of it?
Yes. Oh my gosh. I feel like it's 32 degrees, but I could be wrong. It's pretty cold. It's not like ice, but it's pretty cold.
So how, how do we care for our hair in between the scalp cooling treatments? I know you mentioned, some people with the wig or like the special conditioner and things like that. Are what do you do in between treatments?
So it's 64 degrees. I was like, 32 degrees is not right. It's 64 degrees. I was like, that was such a wrong answer. So
64 degrees.
64 degrees. So in between treatments, I think really the key is to not pull and try to damage the follicles. Because remember, I showed you that picture of the hair follicle, like you can tell when people are on chemo.
Mhm.
So if you're trying to like straighten your hair, you're tugging on the roots, right? If you're starting to curl it. So what I tell patients is to just wash your hair like you normally would. I have kind of thick hair, so like I do this myself anyways, but after I put a lot of conditioner and I'll comb it out in the shower so that I'm not trying to get all these tangles and pull on the roots after. And then it's using gentle products that are sulfate free. I know Paxman, when they send you the cap, they actually send you shampoo and conditioner and all these things and tell you how to use it.
Mhm.
So most of these companies have hair care that they will share with you. And then it's just avoiding stressing it. So I tell patients, I know you want to dye your hair, but you want to keep your hair more. So get it dyed before you start, and then don't dye it for a while, right? And then just being gentle on your hair, right?
Mhm.
You know the things that are going to make it fall out.
Right. So say the patient has gone through their chemo treatments, they had the scalp cooling. Now they no longer need the scalp cooling because they are finished with their treatments. What does that do to the hair? How does the hair react? And what's that, I guess, time frame of when you can go back to doing your hair?
Yeah. So hair grows out about 1/2 to 1 inch per month on average.
Mhm.
So remember, chemo acts on rapidly dividing cells, right? So when patients are done with their treatment, not during treatment, I personally tell them to start taking a hair and nails vitamin to start with like that nutrition to the hair, right?
Mhm.
And I usually will tell them that once it's grown out 1/2 to 1 inch, that they have strong roots at that point, and that's the point where they can start like dyeing their hairs and kind of going back to normal things. As kind of a funny aside to this, after chemotherapy, people lose hair everywhere, including like, their privates and
Yeah.
arms. And, a lot of times like facial hair will grow back like as peach fuzz. So I'll tell people just wax it once. It's like baby hair. It'll go back to like it used to be. But it's funny, like when you know something about hair, they ask you about your hair everywhere. And then, I think hair loss everywhere is important. And so, like a lot of people with stronger chemotherapies, it's not as common with breast cancer, but some people lose their eyelashes. So there's this treatment called Latisse. It's generic now, so it's more affordable. But if you start that after your treatments, it can help both the eyelashes and the eyebrows grow out a little bit fuller and faster.
Hmm. Yeah, I remember losing my eyebrows and lashes and nose hairs. No one talks about the nose hairs. That was a surprise. Um, so, you mentioned that, not all oncologists are up to speed on scalp cooling, right? So what would be some things that patients can say to oncologists who aren't familiar with it but may scoff at the idea?
Yeah, so I think a couple things is I don't think it ever helps to be derogatory or say you don't know, right? That's just
Mhm.
not helpful to anyone. So I think doctors respond well to data. And so, like on the Paxman website, they actually have a library that has a lot of the articles for scalp cooling. So that is a wonderful resource for patients that, if they want their healthcare providers to know more. There's articles out there. There's a lot of review articles. The scalp studies, both the one by Dr. Rugo and I, were published in the same edition of JAMA. And that was several years ago. So it received a lot of attention back then. But, these devices cost money. So they're actually rented by the centers. And then the patients pay for the actual cap and the usage, right? It's through a company, it's a product. And so it's not offered everywhere. So, most of the bigger cancer centers have them as a service to their patients. So I do think there is still a role for the caps because the caps are not devices. You can use those in any center. They work very well. They're just more labor intensive, right? And they can be a little bit more uncomfortable, but they definitely work. So, I do think these are this is one tool that can make the cancer journey easier for patients if we can help them keep their hair.
I saw we had a question live come in. How are you sharing this information to oncologists in other areas? And that makes me also think of like, you're mentioning all these websites and publications for oncologists. What about, is that going to reach those that are in like rural areas as well to get this information about scalp cooling?
Yeah, so I think it's just like any profession. So doctors have to do continuing education. They have to learn, in our center, I have personally done like the grand rounds to educate all the oncologists that we have this service. If it's available, it's worked.
Mhm.
I have had oncologists at my institute where we did the clinical trial that showed it worked say, oh, this doesn't work. We're not going to use it. And I'm like, well, that's not what the data shows. And, kind of politely email them the data to review. And some will review it and some won't. So I think you can't there are mixed feelings about this. I think the data is clear that it does work. It does not work for everybody, right? If you're getting that anthracycline chemotherapy, it's not as effective. But I think that's a choice you give your patients, right? Like if I tell a patient you're getting this chemotherapy, the hair retention is not as high, but if we sequence it in this way, you have a 2 in 5 chance of keeping your hair. And even if you don't keep it, it may grow back faster and fuller, A lot of them are like, oh, I do want that. So I think it's easier for doctors to offer it to patients when we have the devices versus the caps. But I honestly think the way I have seen a lot of doctors learn about it is because the patients are asking for it. And when your patients are asking for something, you're forced to learn about it and be educated about it. And I think the way we get that news out is by outreach. The companies are doing this. They're trying to do grand rounds and education. Every once in a while, it'll make national media, and then people get a lot of questions about it. So I think if a new nausea medicine came out, we wouldn't hesitate to offer it to patients.
Mm.
I think the same is true for like scalp cooling and I equate it to years ago. You guys may not know this, but a lot of insurance companies after mastectomies would not cover the cost of reconstruction.
Yeah.
So there was actually a law passed where if your insurance company paid for the mastectomy, they had to pay for reconstruction because they showed in studies that it was psychologically very damaging for patients, right? And so I don't know if hair is the same equivalent, but losing hair, not having hair can affect psyche. It can cause a lot of distress. And they've even shown this in patients who wear head coverings, like patients that wear hijabs or, I don't know if you guys know this, but Ashkenazi Jewish women actually wear wigs to cover their hair. And they've shown that even those people who go in public with their hair covered are uncomfortable when they lose their hair. And there's some studies that have shown that up to 8% of people may decline chemotherapy because of hair loss. And I think what happens is we don't see that 8%, or it may be a lower number, I'm not sure, because they choose to seek alternative medicines because they don't want chemotherapy. So they never even make it into the centers, which is really sad because maybe they could have been cured and then they don't get their cancer treated and it becomes metastatic and they pass from their cancers without ever getting it treated, right? So I think there's a lot of benefits to this. I think the biggest hurdle is the cost and overcoming that and getting insurance coverage. And there's a lot of strides that have been made in that area. We're almost there.
Can you talk to us a little bit about like how long does it take? Do you wear it the whole entire time of your chemo infusion? Because some of the treatments can take up to like 5 to 8 hours. Are you wearing it from like that very first second all the way like to 8 hours, 8 hours later?
Yeah. So for most regimens, you wear it for 30 minutes before, during, and up to 90 minutes after. There are some certain drugs where you can wear it for maybe, shorter times after. Now, there's a couple nuances to that. In the pre-cooling time, if you have like African American hair, thicker hair, they've shown that maybe 45 minutes of pre-cooling may be a little bit better than 30 minutes. And then there are certain chemotherapies or targeted therapies that don't cause hair loss. So if you sequence those seconds, that infusion time can actually be counted as the post-cooling time. So let me give you an example. Like there's a regimen called taxotere carboplatin pertuzumab Herceptin. We call this TCPH for breast cancer. Out of those 4 infusion drugs, only the taxotere causes hair loss. So if we give that taxotere first, then that 90 minutes of post-cooling time starts right after, while the carboplatin is being given, which does not cause hair loss. And while those biologic HER2-targeted therapies like Herceptin and pertuzumab are being given. So in that particular patient, it may not actually add a lot of time, right? Because they're able to get those treatments during that post-infusion time. So this is, again, like educating the infusion nurses, your facility. Like I still get questions about this when they don't know what to do. They'll be like, Dr. Nangia, what do I do for this?
I mean, like, is there, and talking about like which chemo should you get first in order to maximize keeping the hair? Is that really like an option? Like I always thought the reason why the doctors like said you should have this one first and then this one second, this one third. So it doesn't seem to really matter which one it goes first as long as it's in the taxane family.
Yeah, so it's actually interesting. This question came up by a lot of centers. And, I'm a breast oncologist. I'm going to talk about breast data because that's what I'm familiar with. But in triple negative cancer, there's actually some studies, like the original clinical trials looking at the approval of the drugs was done with that adriamycin first and then the taxane class of drugs. But there are several studies that have shown that if you give the taxane first, that more patients actually do better for 2 reasons. One is there's about a 3 to 5% higher pathologic complete response rate. And the second is that you're able to preserve dose intensity so that people actually can get more of their chemo. And so it's kind of interesting because we didn't really have that data before. So I don't think the sequence for breast cancer, when you're talking about curative intent for taxanes and anthracyclines, matters. And there may actually be benefit in that triple negative subgroup from giving the taxane first. So I have no concerns around that in the breast cancer realm. I'm not really that familiar with the other tumor types to comment on those.
Well, Dr. Nangia, you have been amazing. This has been really informative, and I love the questions that were submitted. I feel we covered a lot. I'd love it if you could give us, maybe 3 takeaways that you really want us to walk away with today.
Yeah, so what I would say is be your own advocate. If scalp cooling is something you are interested, read more, learn more, ask your doctors. And there are some resources out there. I think I'll send them to you. Maybe you can add them to the end of this. But there's like a Rapunzel website, which lists like places that have scalp cooling available and some other tools out there. But I think anyone, anywhere can have scalp cooling, whether it's a cap or a device. There are nonprofits like that here to stay that can help you. And I also feel like it is an important part of your care. So don't, let people tell you that it's just cosmetic. It's much more than that. And I showed you those pictures of my patient who is a college student. Can you even imagine, being in college and losing your hair and then all your friends, like you're just treated different. You can't even be normal when you're trying to be normal, right? So I just think this is an amazing treatment. It's not 100% effective, obviously, but there's a good amount of people that we could keep their hair in, and some people that only get that, Taxol type of therapy have 100% chance of keeping their hair. So you can look at it as the glass half empty or half full, right?
Well, I definitely,
and I'm a half full girl.
Right. And I definitely want to, I hope that the scalp cooling can also be more inclusive and diverse of the different, textures of hair, also. So we'll definitely be keeping an eye on that too. So All right. Well, everyone, thank you so much for joining us today. I just want to, let you know that we'll have the recording of this program on our website in 1 to 2 weeks, and Dr. Nangia will send us some of those links, and we'll make sure that we send those out when we send out the recording. And hey, please make sure to check out Share's website for some upcoming educational programs. Our podcast episodes, our latest November podcast will drop this Thursday. And make sure that you check out our different support groups. And don't forget to follow us on social media as well. So everyone, and Dr. Nangia, thank you so much for being with us today.
You're welcome. Take care.
Okay, bye.